Good afternoon, everybody. Dr. Carla Fry, and today we're going to talk about trauma nursing. So just a broad overview, trauma is one of the leading causes of death in age groups younger than 44. Intimate partner violence is one of those things that we would also include in trauma, and that actually constitutes a much larger portion of the injuries that we see than we would like, of course. And then alcohol-impaired crashes also make up a huge portion of the injuries that we're seeing in the United States. So let's get right in. Now, when it comes to vehicle crashes, motor vehicle crashes, known as MVC, we call those MVC, not an MVA, and that terminology is probably at least a decade old now. So MVCs, a steering wheel to the chest is a pretty common thing to have happen. And there can be, of course, soft tissue injuries, but then all of the things underneath, from the sternum to the heart itself, the aorta, the lungs, of course, as well, and the ribs. So lots and lots of different injuries that can result from that steering wheel to the chest, and we'll talk more about that as we go further into the slideshow. Now, when it comes to trauma, there are phases that we're going to discuss, and a trimodal distribution of mortality. You might say, well, what does that mean? Well, essentially, there are 3 peak times when a person may not survive whatever the incident is. So let's stick with the MVC. So the first peak for mortality is at the scene of the crash, within minutes of whatever the accident is that takes place. And this occurs from major injuries such as brainstem injuries, cord injuries, severing of limbs, injury to the heart, the aorta, the large vessels of the body. So if a person makes it through that initial insult, whatever it is, motor vehicle crash or what have you, the next peak is within minutes to a few hours. And that is typically a failure to resuscitate adequately when it comes to fluid. So if you have somebody who's extremely hypovolemic, they're in hypovolemic shock, that can be a reason why those first few hours, that golden hour of trauma, they don't survive. And also sometimes because of major traumatic brain injury. So many different reasons why, but that next peak, about 30% of the mortality, comes from that minutes to hours point. And then the third and final peak is days to weeks after the crash, after the accident, whatever it happens to be, typically in the critical care unit. And this is the one that's really tough on families because, you know, you've got somebody who survived maybe a catastrophic car crash, and they made it through that. They made it into the surgical suite. They corrected whatever they could surgically, and then to find out only days or weeks later that as they're starting to improve, they develop a clot. They become septic. They go into multi-organ dysfunction because of prolonged hypotension, things like that. So that's a really tough one, and it does make up a full 20% of the mortality that we see in trauma. So not to be ignored. When we have someone who has survived a catastrophic incident, we need to be very vigilant about avoiding complications. Well, there are 6 phases of trauma: pre-hospital, hospital, the definitive care, which is what are we going to do exactly? Do they need to have an operation to correct whatever the injury is? The critical care phase, and then the step-down phase or intermediate care, and then finally on to rehab. And so we'll elaborate on some of these phases, but this is something that in terms of trauma speak, you'll want to know because like TNCC, the trauma nurse core course, they're going to talk about the trimodal distribution of mortality, the phases, the operative phase, the critical care phase, and all of that. So the ED resuscitation piece is key and crucial, obviously, as is the pre-hospital resus. And we really do follow the ABC methodology. You're already very familiar with airway, breathing, and circulation. We just tack on 2 other things, and that is disability and exposure. And disability is not what you might think. This is disability in terms of a person's mental status, right? And so we're just trying to see, do they have any sort of immediate issue with their level of consciousness? Are they alert and oriented? And so a very quick mini mental status exam will establish whether or not they have a mental status disability, or an impaired level of consciousness. And then exposure is exposure to what? Were they exposed to anything hazardous? Were they exposed to extreme heat, extreme cold? So, really a little bit about the situation as to what occurred is important to have here. I had a patient who came in one time who had fallen off of a ladder, and he was painting a house. So he was outside painting a house, and when he fell off the ladder, he had a compound fracture. He had many, many different injuries. He had some burst fractures of his vertebral bodies, but he had a bone sticking out of his arm, and it was completely, totally covered in paint that was now drying on his arm with the bone sticking out. And so, talk about a strange exposure. This is exposure to a substance, the paint, that was all over an open wound. So that's just a simple example, but think about exposure in terms of not just necessarily the environment, but maybe whatever was happening at the time of the accident. In the phases of trauma, when you get to that secondary survey, so you're going to do a primary survey. The primary survey is really just the A, B, C, and D, right? The A, B, C, D, E. So that primary survey is quick. It is not a full head-to-toe assessment. It's really just looking at what I like to refer to as what can kill you now. I talk to my students about that and say this is the priority in trauma. It's very, very different than it is maybe in other types of nursing. So your primary survey, A, B, C, D, E. Then you get to secondary survey, and we use the mnemonic AMPLE for allergies, medications, past medical illness, and pregnancy, if appropriate. And then the last meal, and the events or the environment related to the injury. So we're trying to get more detail here. Now, this is not always possible. The secondary survey sometimes is fairly limited because of the patient's decreased level of consciousness or disability as we look to the primary survey, the D in A, B, C, D, E. But we want to get as much as we can. So this is where if the patient is not able to tell you anything, you're going to want to tap into any family members or anybody who happened to be at the scene of the crash. Sometimes you have to go through wallets or belongings. You really have to play detective a little bit. So it helps in trauma if you have somebody from social services who's able to, to be on scene. When I've worked in level 1 trauma, we would have the chaplain there, somebody from social services there, all sorts of support staff to help you if you have to figure out some things in the secondary survey that are not going to be immediately obvious. One of the really key and crucial pieces of this is the past medical history. We really need to know, what is in that person's history so that we make sure that as we're treating them with medications, interventions, what have you, that we may not do some more harm than good, or maybe that we stop a medication that's crucial that they've been on, those types of things. And then last meal, patients who have suffered trauma are certainly at risk for aspiration. And you'll recall that we talked extensively about ARDS, and that one of the reasons people can go into ARDS is because they have had an aspiration event, and so aspiration pneumonia can lead to ARDS. So we want to know when was the last meal, and then if we're able to get an NG tube inserted and decompress, the belly so that there's not a bunch of gastric content in there that can be aspirated, that would be great. All right, so now we get to the definitive phase. We've gone through the primary assessment where we've dealt with the most emergent situation, trying to make sure that the person survives that initial visit to the ED. Gone through the secondary assessment to try to find out some more details about the accident, allergies, things like that. Then we get to the definitive care. Definitive care is when we figured out, what are the most threatening things that have happened. Maybe they have suffered many, many different injuries, and so we prioritize those injuries. Are any of them going to be surgical in nature? They need to go to the operating room to have some surgical repair of injuries. Are they going to be moved straight to the critical care unit? What have you? Regardless of what the situation is, as the nurse, your role is to make sure that you're communicating as thoroughly as you can about all of the many aspects of the trauma. So using SFAR, which I know that as nurses you're familiar with, is a really great way to make sure that you capture as many details as possible and don't leave anything out. We're going to take a body systems approach to tackling each of the components of trauma, starting with the brain. So head trauma is first, and we'll go from simple to a little more complicated, starting out talking about concussion versus contusion. And a contusion, if you think about contusion, it's really just a bruise. And so while it may cause some injury, it is a little bit less severe typically in nature than is a concussion, which is an injury that results specifically from brain trauma. So a contusion may cause some changes in cognition. You may have a person who has some kind of mild headache and a little bit of an inability to concentrate. Sometimes they have a little bit trouble finding their words, but generally that resolves pretty quickly. A concussion may have more lasting issues, and it may become quite severe. So we really do need to evaluate carefully if a person has reported a change in their level of consciousness, or if they lost consciousness at the scene whenever they had their accident, if they hit their head. Especially if they have nausea or vomiting, if they're showing you symptoms that may indicate that they have something more severe going on, that, perhaps there is some bleeding going on in the brain. And we use TBI broadly, the traumatic brain injury terminology, as we go through these slides. And we just discussed concussion and contusion just briefly, because we're going to really focus more on the critical types of injuries. Here you see a depiction of coup contra coup injuries. And this is important to illustrate for you that when a person has a brain injury, the place that is an apparent injury, and in this case as with a baseball bat to the frontal lobe there, is obviously going to be an area of concern. But you also have typically a contra coup injury on the opposite side with a secondary impact, and that is because the way that the brain moves, and it can't move a lot, but it moves enough that that backward motion, when the head snaps back, can cause an injury that is equal or sometimes worse on that opposite side. It's important that we talk a little bit about acceleration, deceleration when it comes to trauma. If you think about a car crash, put that in your brain right now, and think about when the moment the car hits something else. So let's say it hits something that is not moving. Maybe it hits a parked car. So you have the moment of impact. That's the car hitting into the other vehicle. At that time, the body moves forward quickly and has an impact with something. And let's say it's the steering wheel. So that's impact number one. And then impact number two is that just because the body has come in contact with the steering wheel, that does not mean that the organs have stopped moving. So the outside of the body, the chest wall, may be impacted with the steering wheel, but then the inside of the body, the organs come crashing forward as well. That is impact number two, as the organs hit immovable parts of the body, say for example the rib cage. And then impact number three is that rapid deceleration. And at that time, and this is where the coup contra coup comes in. So if the brain is going to hit, an object, or if it's going to hit the front of the skull, then at the deceleration point, you're also going to have the brain or some of the other organs in the body suddenly stopping and having an impact again on that opposite side, or on the posterior side. So this is important to know. It's a really important concept and something that we'll be talking about a little bit more as we go. With respect to TBIs, we have three major types of cerebral bleeds or hematomas. That is epidural, subdural, and intracerebral. And again, these depictions here should show you hopefully a little bit more detail as to exactly where the bleed is. So if you look to that very thin dura layer, a bleed that is above that is epidural, and a bleed that is below the dura is a subdural. And then intracerebral, which you see in C, the lower image there, is a bleed that is occurring somewhere in the brain tissue itself. So when you're evaluating pupils with a person who has an epidural hematoma, the pupil may be blown or very, very large on the same side as the injury. And this is not always easy to figure out depending upon the location of the injury, but you will typically see the symptoms on the same side, and they may also have have some issues with, with movement. So you may see that they can't move their arm or their leg. Again, same thing. The changes that are occurring, the deficits that are occurring on the same side as the injury, which is a little bit different than we know for like a patient who has a stroke. So that should be one of those hallmark signs that would tell you that this may indeed be epidural. And again, the importance of that is that an epidural bleed is typically an arterial bleed. A subdural hematoma is bleeding that is occurring below the dura. So you see that little thin line of the dura there. So this is occurring below the dura, and it is putting direct pressure again on the brain. So equally damaging and can be very large, but these are typically the bridge veins that are bleeding. So this is usually venous in nature as opposed to being arterial in nature. All kinds of deficits can occur, but you don't see that same ipsilateral or same-sidedness as far as the deficits go. It may be opposite. It really just depends on the location, but they don't have that period of lucidity. When they lose consciousness, they don't awaken again the same way that an epidural hematoma would do. Doesn't mean these are less serious or more serious. They can be equally lethal, and we have to respond to them. But because they're venous, they can tend to bleed a little more slowly. Now that's important because you think, well, that's better, and you're right. But because they can bleed slowly, sometimes they're missed. Every now and then we'll have a person who comes in who did have a head injury, and initially you don't see much of anything, and you send them home. You think, oh, they just have a concussion, they're fine. But days later, they can really present with some major symptoms, and that is because they've been having a slow leaking occurring below that dura, and now they have a significant hematoma. So when you look to your text, you'll see that subdural hematomas are classified as acute, where we had a car crash or what have you happen, and right away they develop their hematoma. Sometimes they're subacute, and they may occur within days of the incident, within hours or days of the incident. And sometimes they're chronic, and that is that they had the accident and many, many weeks even went by before they experienced symptoms that are severe enough that brought them to the emergency department. I had a friend who was hit with a golf ball, and that very thing happened. He initially had a big goose egg, of course, and it hurt, and he had a bad headache, and he even vomited. He went and got seen. They didn't find anything. He went home, and over the course of several weeks, he began developing changes to his personality and showing signs of irritability and forgetfulness, and just progressively worse headaches and symptoms, such that his wife asked him, please, can you go in and be seen? And he had a fairly large hematoma at that point in that developed over the course of many, many weeks. So at that point, of course, he had surgical intervention and everything was okay. But, had that gone unchecked, it could have gotten worse and worse and gone to the point where he really ended up with a very bad outcome. Intracerebral hematomas are occurring somewhere in the cerebral matter, in the brain matter. And depending on the location, that is what the symptoms are gonna look like. The symptoms will be very dependent upon the location of the bleed. So you may see that speech is impacted, maybe balance is impacted, maybe there's left-sided weakness, etc. And it really is just going to depend on the location of the bleed. On this slide, you see a high-velocity missile injury, and this is trying to depict for you just exactly what happens with a missile injury. Sometimes these are a clean wound in that they go in and out. There's an entrance and an exit wound. Exit wound can be worse than the entrance, and sometimes they're not all the way through. Regardless, that blast effect, that high velocity, is gonna cause an increase in pressure, and so it's the pressure that tends to be, and that's the secondary injury we're going to talk about in a minute here. That pressure tends to be even more damaging at times than the primary injury, which is in this case a bullet wound. You see hemorrhage around the area where the projectile has entered, and then beyond that you see in the blue edema, and that edema is what's going to cause the increase in intracranial pressure, and it can cause herniation of the brain, such that we would have compression on the brainstem and a loss of any of the autonomic functions, such as the ability to have spontaneous respirations and control of the heart rate. Well, this is a busy slide, but it's an important one because it's showing you that not only do we have to worry about primary injury, but also about secondary injury. So when a person has a head injury occur, of course they can immediately develop a brain bleed, and that brain bleed can expand, or it can really do such catastrophic damage to the brain that they may die at the scene. But what more oftentimes happens is that brain bleed puts pressure on the delicate brain tissues. Sometimes the brain is actually exposed to bleeding, and the blood itself is extremely caustic to delicate brain tissue, so it can do damage that way. But the pressure in really what is a closed system is usually the problem, the biggest of the problems. So that increased pressure that's created from a bleed, there's no space in the brain for a bleed to take place, so it's putting pressure on the tissue. The tissue is going to become hypoxic, and when the tissue becomes hypoxic, you enter into a situation where lactate is produced, and the breakdown just continues. So we see intracranial pressures rising, and in this case, when intracranial pressures rise, if they're not handled quickly, those intracranial pressures will be so severe that the brain will have no choice but to herniate in some direction. Sometimes that direction is actually to herniate outside of the body, and you can see brain tissue coming out through the nose or through the ear, which is pretty horrendous. And other times you'll see the brain herniating in a downward fashion, and so I'll show you a depiction of that in a few minutes. But that pressure must be relieved, because if it is not, you're going to see brain tissue. Think about time as tissue. You're going to see brain tissue becoming ischemic, and then cell death occurring, and at that point the damage is going to be irreversible. All right, and this is just another depiction of what happens after the injury. So from the injury, the direct damage takes place, and then from the direct damage we develop edema, there's vascular dysregulation, the hematoma puts pressure, the pressure is going to cause the intracranial pressure to rise. As the intracranial pressure rises, there's cell death, apoptosis, and necrosis. So we've got to get a handle on traumatic brain injuries quickly. Time is of the essence when a person presents with a TBI. So we've talked about subdural hematomas, epidural hematomas, and intracerebral hematomas or bleeds. But this is a little different. DAI, or diffuse axonal injury, is injury that occurs in kind of a scattered fashion, if you will. And this happens oftentimes not as a result of the primary injury, but as a result of the secondary injury. So the brain tissues, as they're damaged with increased pressure, can be damaged so much that there's stretching and pulling of the axons and the dendrites, and they can tear, they can shear off completely, or they can just be stretched. So when we see this, and it's usually days, sometimes weeks after the accident, it can be a really bad outcome. So you don't want to see DAI because it's harder to handle, it's harder to manage. We think about, if there's a bleed, a subdural bleed, that bleed may be able to be evacuated, and then with time some of that blood is reabsorbed, and the person can have a pretty decent recovery. But with DAI, when these little tiny dendrites are stretched, pulled, torn, or sheared, they sometimes don't recover at all, and this results in massive disability and sometimes a chronic vegetative state. So this depiction just shows you a little bit about blood pressure management. We're going to talk about that in a few minutes, the use of medications and drains, and so I'm not sure that it's all that meaningful to you until maybe after you've learned a little bit more about the whole, the sum total of TBI. Neuroassessment is key and crucial. In the primary survey, you do a mini mental status survey to see what the level of disability is. But then you want to go further and make sure you do a full Glasgow Coma Scale. This is something you're probably already familiar with, but if you're not, make sure you take some time to understand it. And when it comes to verbal response, if a person is intubated, instead of using a 1 because they can't speak, we usually use a 1 with a T. So 1T, in other words, tube, that they have a breathing tube in. And that helps a person to know, if they came along and looked at that Glasgow Coma Scale, that the none in verbal may actually be different if the person didn't have a breathing tube in place. So to calculate and talk about intracranial pressures, we first have to have an understanding of the mean arterial pressure, or the MAP. And I know you see these on a regular basis, but when you see that MAP of 73, do you really know where it comes from or how it's calculated? So the MAP is equal to 2 times the diastolic plus the systolic divided by 3. All right, so we can calculate this very easily. 2 times the diastolic being 55, that's 110, plus the systolic, which in this case is also 110, divided by 3 equals the 73.3, and we'll just round down. So you've got to be able to calculate and know the MAP in order to calculate cerebral perfusion pressure and really manage a person's intracranial pressure well. All right, so what is cerebral perfusion pressure? Cerebral perfusion pressure, think about that in an oversimplified way as the brain's own blood pressure. It is the amount of blood flow that I must have in my brain in order to have normal neurologic function. We would like very much for that CPP, cerebral perfusion pressure, to be 70, right? We'll settle for 60. That's probably okay, but we really would like for it to be 70. All right, so go back to thinking about the MAP for a second and how you calculate that. And in the previous slide, we had a MAP of 73. So if we have a MAP of 73, which is a decent mean arterial pressure, right? That should be adequate perfusion for the body. That MAP of 73 minus the intracranial pressure is what's going to give us our CPP. So let's say that the ICP is normal. That's between like 5 and 15. 73 minus 10, let's give an ICP of 10. 73 minus 10 is 63. And that's a decent enough cerebral perfusion pressure. The person is still probably awake, alert, and oriented. Again, we would like it to be 70, but we can tolerate 60. All right, so a CPP of 63. Now let's go into the situation where we have a car crash. The person has had maybe not only a traumatic brain injury, but they've also had a pelvic fracture, so they've had a fairly significant blood loss. So their MAP to start with is 50, right? So they're hypotensive and they have a low mean arterial pressure. There's no way you could have a cerebral perfusion pressure high enough if MAP of 50 minus ICP is going to equal the CPP. So already, even before we factor in an elevated intracranial pressure as a result of a TBI, we already know that the CPP is too low. So let's take that, let's go ahead and follow through with that. So the MAP is 50, the person is hypotensive and the MAP is 50, minus an intracranial pressure, which is elevated. In this case, let's say the ICP is 20. So 50 minus 20 is 30. A cerebral perfusion pressure of 30 is not compatible with life. The tissue is going to, it's already ischemic, and the person is already, their brain is already starved of oxygen. They're severely, at this point, impaired neurologically, and they will move and progress towards brain death if we don't do something to fix that. So how can we fix the cerebral perfusion pressure? Well, think about it. You have the MAP and you have the ICP, both of which you can have some impact on. So if your person is hypotensive as a result of blood loss, you have got to do something to repair that scenario. So maybe they have to go to surgery to stop the bleeding. You may have to give blood products. You might have to give fluids. You may have to give vasopressors. You've got to get that MAP up high enough that we can maintain a CPP of at least 60. So if their intracranial pressure is high, we can also work on relieving that pressure in a number of different ways that we're going to talk about. But if we're unable to drive down the intracranial pressure quickly, the very first thing we want to do then is drive up the MAP so that at least with that little bit higher MAP, they can tolerate that elevated ICP in the short term. So we may put a person who is hypotensive on vasoactive drugs to raise their blood pressure. But in some instances, they may not even be hypotensive, and you still have to put them on vasoactive drugs because you've got to drive that MAP up even higher than normal. So we may need to get the MAP all the way up to 85 or even 90 to offset the elevated intracranial pressure. A MAP of 90 minus an elevated ICP of 20, 90 minus 20 is 70, and that's a decent perfusion pressure, so the person should be, a little bit more neuro intact, right? So you can work on both, and so keep that in mind as we talk about the interventions here. And you may say, well, how do you how do you monitor ICP? Well, there are several different drains that can be placed, or little sensing devices in the ICU setting that can help monitor the intracranial pressure. And we won't go too far into those. That's really a whole other lecture. But just suffice it to say that we're using a monitoring device like a vent drain to know exactly what the ICP is. And then, again, you've got your map by virtue of your blood pressure. So we have somebody who's got an increased ICP. What is that going to look like? They will probably be confused if they're awake at all. They may have shallow breathing. They may experience nausea and sometimes projectile vomiting. That's not uncommon. Their blood pressure, at least initially, will probably be increased. And this is the body's own mechanism by which to try to maintain a decent cerebral perfusion pressure. So the BP increases initially in response to all that is going on. But unfortunately, this compensatory mechanism doesn't always stay in place. If they're awake enough to tell you, they probably have a very severe headache, but many times you won't have the ability to really talk to your patient because they're already neurologically impaired. Signs of increased intracranial pressure. Again, kind of a busy slide here. This is using the acronym MIND, M-I-N-D. Mental status changes. That's going to come early. That's one of your earliest signs. Irregular breathing, like Cheyne-Stokes style breathing, is going to come much, much later. So your early sign is a change in mental status, and it could be something as simple as them being very restless, or just kind of becoming confused, and then it will progressively get worse. Nerve changes, oculomotor nerve changes like double vision can happen. Pupil changes where they have an unequal pupil response on the left and the right. And then when they progress to brain death, maybe even doll's eyes, and we'll talk about that in a minute. And then decorticate or decerebrate posturing, and I'm going to show you another slide that details that so that you can really see exactly what I mean. More signs of increased intracranial pressure. In this instance, the acronym CRUSHED. Cushing's triad, which is very late, and that's where the brainstem does go on to herniate. A positive Babinski, where the toes fan out. So if you try to do a Babinski where you scrape the bottom of the foot with the hammer or something like that you're using, being careful not to break the skin open, the toes should curl downward. But when the toes fan out, that's a positive Babinski, and that's a bad sign. It's typically a sign that there's something going on neurologically. Unconscious is very late. Seizures tend to happen at different intervals, really depending on the person's threshold. Headache, if they're able to tell you. Emesis, projectile at times, and then continued deterioration of motor function. In some cases, they may be hemiplegic, where they are completely unable to move on one side of the body. Here you see decorticate and decerebrate posturing. Decorticate is with posturing that brings the extremities to the core of the body, and then decerebrate is where the extremities will sort of fan out away from the body. And of the two, decerebrate represents a worsening neurostatus. With respect to the types of drains, there are many. There are burr holes and there are drains that can be put into place, or we can take out a piece of the skull to relieve pressure as well. So there are many different interventions to relieve elevated intracranial pressure, and we're not going to get into all of the specifics of each of those today. I just wanted to show you an image of a drain that is in place and talk to you just briefly about it. For patients who have a portion of their skull removed, a piece of the skull is removed, one of the plates, what we used to do way back in days of old was take those things, put them in a plastic container and refrigerate them, and then when it was safe, when intracranial pressure was lower, to put the piece back in, it would surgically replace it. What they found was that was oftentimes not a viable piece of material after some time being in plastic in a refrigerator. So now what they do is if they have to take out a plate, they'll take out that piece of the skull and they'll implant it in the patient's body. And usually it's somewhere in the chest wall, so it kind of reminds you of a little bit of like where a pacemaker would be. It's implanted just below the skin, keeps it safe, keeps it from getting lost and keeps the tissue viable so that they can put that back as soon as swelling has subsided. Here you see an image of a ventricular drain, and so this is a drain that is placed very, very carefully into the ventricles of the brain to eliminate or remove the blood that has accumulated as a result of the bleed. Now this is a pretty serious matter. You know, having a patient with a vent drain is really challenging for nursing, and oftentimes there'll be one-on-one care because you do need to be so careful with it. You see here in the illustration a dotted line with a 0, and it's zeroed at the tragus of the ear, and if it is not maintained at that particular height, you can have major problems. So I've heard stories, horror stories of this, with vent drains being placed lower than the patient's ear, and when they are in fact an excess of CSF, cerebral spinal fluid, can be pulled out, essentially creating a vacuum, if you will, and patients can have brain tissue actually coming out through those drains. So it is extremely imperative that they are maintained in such a way that we're not pulling out extra fluid, that it is just draining simply by virtue of the gravity itself. And so when you're going to care for patients who have vent drains, you do need specialized training for that. Here's another image of the vent drain showing you the zeroing, obviously maintaining strict aseptic technique. The patient is typically sedated. They're going to be sedated, and they're going to have a chemical paralytic on board, so they're not going to be awake thrashing around because, again, it would be quite risky and they could potentially dislodge the catheter too. So these are all drains, burr holes, removal of a piece of skull, all meant to help as an intervention to reduce intracranial pressure, thereby saving the brain. Now, here are some of the interventions that can be done medically to decrease intracranial pressure. First at the top there is osmotic diuretics. We may administer diuretics to help to maintain the serum osmolality between 295 and 320, and in doing so, this will help to manage the ICP, keep the fluids balanced so that intracranial pressure doesn't rise. Maintaining blood pressure, with a mean arterial pressure being the key number that we're looking at, to make sure that we don't allow the patient to become hypotensive. If they become hypotensive, as I was showing you with the CPP, that decrease in MAP minus ICP equals CPP. If you have a decreased MAP and it gets too low, they're hypotensive, they're definitely not going to be perfusing their brain tissue. Hyperventilation is something that we need to look at very carefully with all of our patients who have traumatic brain injury. And the reason is that hyperventilation helps to blow off CO2. So we cannot afford for a patient to become hypercapnic. In other words, they cannot have high levels of CO2. And the way to drive down CO2 is to hyperventilate. So we would turn their, by virtue of managing the ventilator settings, we would turn their vent settings up to a rate of maybe they're breathing 22 or 24 times per minute by mechanical ventilation. In doing so, we drive that PaCO2, the CO2, down to at least the 25 mark, if not even a little bit lower than that. And when we do, what we can accomplish with that is we can make sure that we don't have a situation where there's a problem with the vasoconstriction and relaxed vessels in the brain, right? Vasoconstriction is what we're looking for, and that might sound counterintuitive, but we need vasoconstriction because vasodilated or dilated blood vessels are going to increase the intracranial pressure. So we're looking to lower the CO2, keep the vasoconstriction in place, and thereby decrease a little bit the cerebral blood flow to the point that it does not cause an increase in pressure. Now, there's a fine line to think about that when it says decreasing cerebral blood flow. We can't decrease it too much. We got to be careful not to decrease it too much, right? So we need to keep it just right, and that's where monitoring the CPP continuously comes into play. We're trying to keep that cerebral perfusion pressure around the 70 mark, not too high, not too low, but just right. And oftentimes what this takes when it comes to nursing interventions is it takes changing IV fluids, changing the vasoactive medications, changing the ventilator settings, there's quite a bit involved in maintaining an optimal CPP. So again, these patients are oftentimes going to be one-on-one care. Some other nursing considerations. Here we're going to use the acronym PRESSURE. Position the head of the bed to at least 30 degrees. So they always need to have the head of the bed elevated, right? And the head needs to be maintained midline. A lot of times we won't even use a pillow. We need to keep things all aligned properly so that we can allow for blood return to the heart and prevent any further problems with increased pressure. Prevent hypoxia and make sure that we prevent a patient from having hypercapnia. And again, we've talked about that already as a means to make sure that vasoconstriction keeps the ICP down. Elevated temperature is something that can be really dangerous, and especially if we're thinking the patient may potentially be becoming septic. We need to be keeping an eye on this for other reasons, but we need to keep the patient at an optimal temperature. So this means that most of the time we're gonna be taking core temperatures, and we don't want to increase any pressure or stimulation. So sometimes they'll use the temp scan on the Foley as opposed to taking rectal temps. Maintaining the Glasgow Coma Scale, at least so that it's not worsening. Now, if your patient is sedated, not on a ventilator, you're not going to really be able to tell. But you try, even when they're sedated, you try to have moments of sedation vacation where you can see, how responsive they are. And that all depends on how new the head injury is, whether the physician is going to want to bring the patient up from their medications and see what their Glasgow is or not. And sometimes we have to wait for several days before we can even do that. Now, when it comes to eye care, it doesn't take any time at all when a patient is unconscious, intubated, sedated, for them to develop dryness that can cause sores on the eyes. So you're going to use something called, well, there are many things out there, but usually Lacrolube. And instead of it being just eye drops, it's eye ointment. And so you're going to very carefully administer that eye ointment. And then depending upon whether or not the patient's eyes are remaining closed in kind of a voluntary fashion, or if they're opening because they're sedated and they're unable to control that, their eyelid, you may have to tape the eyes closed. And so you can put a special gauze that's shaped like the eye in place, or you can just use 4x4s and fold those over and very lightly tape them to keep the eye closed, so that we make sure that they're not having exposure to the air and having damage that when they finally do wake up, maybe they have permanent damage to their vision. Use of barbiturates and vasopressors, many other different medications, including anti-seizure medication, may be needed. And we may use hyperosmotic drugs to control edema, because cerebral edema will in fact worsen the secondary injury to the brain. Managing edema is important, and so we tend to keep these patients a little bit on the drier side overall. And that may mean that if their blood pressure is low, you may have to use vasopressors as opposed to using higher rates of IV fluids. So the intake and output has to be very carefully managed. We really do want to keep them even or a little on the dry side. We definitely don't want to fluid overload our patients, because it will only serve to worsen cerebral edema. If a patient has such a severe brain injury and brain bleed that it continues to put excessive pressure on the brain tissue and we're unable to maintain that ICP between 5 and 15, which is the normal range, the longer the ICP stays high and uncontrolled, the more damage there's going to be, the more secondary injury is going to occur. And with that secondary injury and all of the changes, the cellular modulation that takes place, we may see more and more tissue death. The other thing that can happen is pressure can continue to build. And as pressure does continue to build in that closed box system, sooner or later brain tissue will have no choice but to find its way out, right? And so the herniations that can occur can be extracranial, and I mentioned that. And sometimes if there's an injury sufficient to cause the skull to be cracked, you can see brain tissue coming through the crack in the skull fracture. Again, can come from out of the ears and the nose as extracranial. if in fact you're caring for a patient who has brain tissue coming out of their nose or of their ears, or they're leaking from another injury, another fracture, you want to cover that up. The outcome is not going to be good. You certainly don't want the patient's family to see that. And I've had nurses ask me before, when they've seen brain matter coming out through the nair, should I suction that? And the answer is absolutely not. You just take a 4x4 and you're going to want to, put that across the nose, tape it, make sure that it's not visible, because it obviously would be extremely distressing. And then, pretty much at that point, it's going to be a matter of waiting until the patient fully herniates and is brain dead. But also when the brain stem ceases to function correctly, then all of our autonomic functions don't work. So they'll either have a bradycardic incident where their heart rate will brady down, they'll slow down to the point that they'll become asystolic, or in some instances their temperature fluctuates extremely wildly. And then when the herniation is completed, we do brainstem testing and we would pronounce the patient at that time. If you have somebody who's got a Glasgow Coma Scale of 3, that is about the lowest, that is the lowest Glasgow Coma score you can have, that patient definitely is approaching brain death. And in that case, you would definitely want to go ahead and notify the organ procurement folks. So that is a mandatory phone call, and we'll talk about that a little bit more in another lecture. But with generally speaking, the hospital has a protocol, and the organ procurement organization, OPO, also does that. When a Glasgow Coma Scale score of 4 or 5 is evident, that you would go ahead and pre-call so that they can open up a case and begin to learn about whether or not this person may be a candidate for donation. But at the point where you had a GCS of 3, you would definitely make that phone call. So determining brain death can be done in a number of ways, and we usually do 2 or 3 tests to make sure. An EEG, a flat EEG, is obviously going to be a really profound finding, but there are some other things that we can do even before the EEG, and they're a little bit easier and quicker to do. And one of them is what we refer to as doll's eyes. So in this image, you see that the practitioner is turning the person's head to the right or to the left and then back to midline. Now, I'm not suggesting that you turn it quickly because you don't want to do any damage, and you certainly wouldn't even attempt to do this type of a test for brain death if somebody had a C-spine injury. But in the absence of that, if you turn the head to the side, when you turn the head to the right side, the eyes should deviate to the left. When you turn the head to the left side, the eyes should deviate to the right. That is normal. But in doll's eyes, the eyes follow the head. The eyes follow the head movement. So if I turn the patient's head to the right, the eyes, the pupils are also going to stay right. And that is an abnormal finding, referred to as positive doll's eyes, and indicative perhaps of brain death. Another thing we can do is called cold calorics, where we inject cold saline solution carefully into the ear canal. And when that is done, the eyes should deviate over to the direction that the fluid is being administered. And if the pupils stay forward and do not move towards the cold calorics or towards the cold saline injection, that is another indication of brain death. Here's an EEG showing you a totally flat EEG for cerebral death. It's rare that the EEG is literally totally flat. It's really rare, actually. There's usually a little bit of a wave left, and so you really do want to indicate or have many different things to take a look at. They'll do apnea testing at times too, where a patient is taken off of the ventilator, and you stand there and you wait for 5 full minutes to see if they take a breath. And I have to say that having participated in that many times, it is extremely unnerving to do that. And if you have to do it, you have to be ready that the patient may code. So if they don't already have a do not resuscitate in place, you pull them off the ventilator to wait 5 minutes to see if they take a breath and they code, you're in a really precarious situation. So it's not something that I recommend to physicians when they talk about it. And I really hate to be involved in it because it really is tough. 5 minutes off the ventilator with no spontaneous respiration is a recipe for somebody having a cardiac event, in addition to their lack of respirations. So many different ways to determine brain death, usually verified by 2 practitioners. And brain death in the state of Florida, as in most states, is legal death. So we can really come upon some ethical dilemmas, and we won't talk too much about those today, but if your patient is declared brain dead, then the next steps would be to find out if organ donation is a possibility and to get the family in place so that they can see the patient one last time, and then they are removed from the ventilator. And they're removed from the ventilator because they are legally dead. So it's not a matter of they have to be made a no code or anything like that. Brain death is death, and so that would mean that they would come off of life support and they would be left, left alone until their heartbeat would totally cease as well. Sometimes family members like to be in there for that. It can be absolutely heart-wrenching, of course, but if you're able to facilitate having the patient's family member there at that time, certainly that would be preferable if everybody's okay with it. All right, so summarizing traumatic brain injury, we talked about intracerebral, we talked about epidural, and we talked about subdural bleeds, as well as concussions and contusions. And the most important takeaways from that are that you recognize signs and symptoms, do that thorough assessment, really get good at the neuro assessment component. Act quickly when you see neurostatus changes, or if you see pupils that are unequal. Those things are definitely signs, with a change in level of consciousness being early and change in breathing pattern being very, very late. And then understanding all as well as you possibly can cerebral perfusion pressure and how to maintain that cerebral perfusion pressure at 70, ideally, by manipulating, if you can, the MAP and the ICP, and then all of the things that you need to do to keep ICP low. Those are extremely important nursing and medical interventions. So as we move away from traumatic brain injury and begin to talk about maxillofacial injuries, the overlap is that you need to assume, if you have any maxillofacial skeletal injuries, you need to assume that there is a TBI until proven otherwise. So these patients may come in looking pretty bad. Facial injuries are dramatic in their presentation, in that this is a very vascular area, so they tend to bleed quite a lot, and the swelling is profound, and oftentimes it's really, really quick. So when you get somebody in, usually it looks a lot worse than it is, but regardless, you need to assume brain injury, and you need to get that CAT scan right away to rule out any brain involvement. The other thing we need to do right away when we have maxillofacial skeletal injuries that look like they have the potential to swell even further, and believe me, they will, is we need to make sure that the airway is protected. So when a patient comes in with facial fractures, it's best to err on the side of caution and go ahead and sedate and intubate. Even if you turn around and extubate the patient the very next day, it's ideal to go ahead and get that airway secured just in case swelling is going to get worse. So what you're looking at here in the illustration A, B, and C is Lefort fractures 1, 2, and 3. This is the way that we classify skeletal injuries of the face, and you can see the breakaway there at the top at the jawline, Lefort 1, that being the least severe, moving to Lefort 2 up near the orbits, and then 3 across the orbit, and so this one being obviously the most dangerous and the most damaging. With these facial fractures, you need to be thinking about whether or not CSF is going to be impacted, and sometimes people will leak cerebral spinal fluid, and so if they have a runny nose, if they have a clear drainage from their nose, you should assume that that's CSF and have it tested. Cerebral spinal fluid is usually positive. Well, it is positive for glucose, and so you can glucose test it to be sure. So we need to be examining the possibility and watching for that. We need to be, of course, mindful. We talked about the airway already. And then mindful of the sinuses, because if the sinuses are impacted by these injuries, infection can really set in quickly, and the patient can become septic. And really, sinus infections are notoriously difficult to deal with. So lots of considerations here. With these types of injuries, your patient is usually going to need to have surgery, sometimes several surgeries. You're going to use ice, but you need to do so carefully because using ice can be damaging to the tissue. So keeping the head of the bed elevated using ice and pain medications, keeping them sedated, managing anxiety, those things are all key and crucial. If the jaw needs to be wired shut, which is not at all unusual, you're going to need to have the wire cutters right there at the bedside. And this is extremely important because if your patient has an episode of vomiting and you don't get that wire cut, they will aspirate all of that content into their lungs and potentially end up in an ARDS. So wire cutters need to be at the bedside, tape them to the wall, put them in a location that everybody can easily see them. And then when you do the handoff between shifts, you need to talk about the location of the wire cutters and literally show the wire cutters to the next shift oncoming so that they know exactly where they are. Now here's just another view of the maxillofacial fractures, Lefort's 1, 2, and 3, with Lefort 3 again being the worst and the most damaging. And typically these cases will involve many surgeries before it's all said and done. The management, we talked about the wire cutters already. We need to initiate enteral feeding sooner rather than later. But importantly, as a nurse, when you have someone with maxillofacial fractures, it is above your pay grade to even think about putting in an NG tube. You can Google it. There are photos out there of NG tubes ending up in the skull instead of down in the belly. So when somebody has injuries that may involve the hard soft palate, their facial fractures, let the specialist put in the feeding tube and you stay far away from that. Making sure the head of bed stays elevated. Go ahead and have antiemetics ordered around the clock instead of PRN so that we don't have a risk of a person becoming nauseous. Have them evaluated for swallowing as soon as it's appropriate to do so. And again, if the jaw is wired shut, keeping those wire cutters always at the bedside so that they're handy in case we need them. Now let's move to thoracic injuries. Thoracic injuries encompass quite a few things. Coming back to the mechanism of injury, we need to think about whether or not this is blunt force or penetrating trauma, and which of the vital organs may be impacted. So just a quick view here of the anatomy and physiology. So when we talk thoracic, we're looking at the aorta, the lungs, the heart, and the trachea, the visceral pleura, the vena cava, all these things. So here, when you're looking at this photo, thinking about blunt force trauma, here's an image that shows you that phenomena, if you will, of the crash taking place really, almost threefold. So the car stops, the body stops, and then the organs stop. And when the organs stop, not only do they stop forward, but then they're going to bounce back. So you may have those injuries both anterior and posterior. One of the things that's pretty rare, you don't see this all that often, but that can be really dangerous, is a flail chest. And a flail segment is when you've got at least 2, usually 3 sections of the rib that are fractured on both sides. And so what it creates there is a little space that will change in pressure. The pressure becomes decreased in that area when the rest of the chest expands. And so it's pretty easy to see. You have to have your patient undressed, but when the inspiration happens, normally you'd see the whole chest expand. The chest does expand, but that particular area will actually be pulled inward. And this can be very dangerous. And so when you see this, when you do the primary assessment, you've got to have your patient undressed to see these kinds of things. You will miss injuries if you don't have your patient fully undressed and exposed. So a key piece of trauma assessment, undressed head to toe. And when you're trying to look at the chest and the structures that we're talking about now in the thoracic region, stand at the head of the bed as if you were going to intubate the patient. Stand there and look down so you have your patient as flat as you can, make sure that their body is well aligned, and then look to see, is the trachea midline? Do you see chest rise and fall on both sides? Is there any segment that looks like it's like it is decreasing in pressure or being pulled inward as the person does take a deep breath? When it comes to the diaphragmatic ruptures are pretty rare. They typically come from penetrating trauma. So you don't usually see this with like a steering wheel incident. You see this more from penetrating trauma. And when there's penetrating trauma to the diaphragm, the risk that we will see is that the belly content, the peritoneal content, bowel, and even stomach can end up in the chest cavity. And you can well imagine the risk for sepsis that has. So these can be extremely life-threatening, and oftentimes the outcome is poor. If you think back to that trimodal distribution of mortality, the outcome can be poor well down the road past the surgery. This is definitely, when it comes to treatment, this is definitely a surgical intervention that is going to be needed. So when we see ruptured diaphragm, it's emergent, and the surgery is really the only thing that we can do to fix that. Patient's going to be intubated. We're going to support them from a respiratory standpoint and get them to surgery as quickly as possible. A tension pneumo is something that unfortunately is fairly common in trauma, and also sometimes we create tension pneumos when we're trying to insert central lines. But a tension pneumothorax is when air is leaking outside of the lung and pushing on the lung itself. So this visual is pretty good. It's showing you that space around the lung, pressing on it, putting pressure on it. And as it puts pressure on it, of course, the ability for the lung to expand becomes less and less. And the more pressure we see, the more push there is centrally. So eventually you'll have a deviated trachea in the trachea. So the trachea is not midline, it is pushed over to the left or to the right. In this instance, we're looking at, that's the right lung, so it's putting pressure on the right side over towards the left. Trachea is going to deviate to the left. There will be absent breath sounds on the collapsed side, and it will not be very long before your patient with a tension pneumo goes from being in severe distress to being unresponsive to being in pulseless electrical activity, or PEA. They'll code. So they'll code and die. This is an absolute emergency, and it's really fairly easy to resolve, but it has to be recognized and it has to be managed very quickly. So in the case of a tension pneumo with a car crash or a trauma, these are the patients who may not ever even make it to the hospital if this happens at the scene and it's not caught quickly, if EMS doesn't know what to do when they get there. So important that we understand what the treatment is for this, and the only treatment that there is to decompress that area of air that has gotten stuck in that cavity. This is done, it can be done with an angiocath, and it's usually between the second and third intercostal space. Nurses who have ACLS can be trained to do this, and believe me, if you don't do it, your patient won't survive. But really, we just walk the needle. It's always above the rib, so we call it heaven above and hell below. So you walk a small angiocath needle above that third intercostal space, and when you do, as soon as that angiocath hits that area where there is air trapped, it will give you a hissing sound, the lung will reinflate, and magically your patient is fine and becomes responsive again. It's really absolutely, it'll happen right before your eyes. So if you've never seen it done, I encourage you to watch a YouTube video to see how a tension pneumo is relieved. It's a simple procedure, one that obviously requires some technique because you do have to stay above that rib, otherwise you run the risk of damaging nerve. But once it's learned, it's something that can be done readily by advanced providers and even by nurses with ACLS. Here's an example or a depiction of closed versus open injuries of the thoracic cavity. So a closed injury, blunt force trauma, creating a tension pneumo on the left. Again, you see that blue space. That's the area where air has entered the cavity, and that air that has entered the cavity has entered by virtue of the lung being damaged. So the lung has released air into the cavity. So the lung itself released the air into the cavity. Now the cavity presses on the lung and further damages and collapses it. Versus an open injury, which is air coming in from the outside. Either way, they're going to really create the same problem. They may be treated slightly differently, and certainly the open injuries are a little bit more risky as far as sepsis goes, and sometimes you have more bleeding that way. But either way, they're going to create tension, and ultimately they're going to collapse that lung and cause the person to code. Here's a hemothorax. So hemothorax is blood, pneumothorax is air. And just by virtue of thinking about gravity, a hemothorax is going to be low in the lung base, right? Where air is going to be air rises. So air is going to tend to be higher. So a pneumo that is a hemopneumo, where you have both blood and air, is treated with a chest tube that would be a little bit more centrally located. Whereas if you're putting in a chest tube for just air, the pneumothorax, that's usually a smaller gauge chest tube, and it's usually going to be inserted up higher. If it's just a hemothorax, that's a chest tube that's going to be a little bit larger, and it's going to be put in lower in the chest wall. So you can walk into a patient's room and begin to do their assessment, and just by virtue of the location of the chest tube, you can tell, is it a hemothorax, is it a pneumothorax? Is it up high, is it down low? When it comes, excuse me, when it comes to these types of injuries, if they've got a pneumothorax, they're going to be dyspneic, they're going to be tachycardic, so fast heart rate, fast breathing pattern, very, very anxious, a feeling of impending doom, using accessory muscles, can't lay down, have to sit up or lean forward to breathe. Sometimes the or nasal passages are flaring. You can see cyanosis and abnormal ABGs if it's been going on for some period of time. So all of those symptoms are something to look for. Usually that very restless feeling and very anxious feeling happens right away. So sometimes that's the first warning sign you get. And then it's going to be much later before you begin to see that shift with a tension pneumo. So that's not going to happen until things are getting pretty far along. So you need to watch for those earlier signs and catch them hopefully before it gets too far out of hand. Care of chest tubes. We won't go into that too much today because it's pretty basic. This is a critical care course and you already know how hopefully to manage a chest tube. But suffice it to say that intake and output needs to be monitored closely in a trauma patient especially. So if their chest tube is draining only minimal amounts and then suddenly you have 100 or 200 in an hour, that's something that you need to report. So if they're draining a lot and it's consistent, report that. That's not as big of a deal as suddenly having a huge amount of drainage, which might indicate that there's still something bleeding internally. Here you see the patient with the chest tube down in the lower aspect of the right lung field. Likely this is a hemothorax that we're dealing with. When it comes to care of chest tubes, it can be kind of complicated in some regard, and so I like to refer people to Atrium University. Atrium, the maker of the chest tube materials and the evac system, the drain, and they have a wonderful website with a lot of great tutorials and training. So if you feel a little rusty on caring for patients with chest tubes, I encourage you to take a look at Atrium University. I think it's really, really well done. Now let's talk a little bit about cardiac and vascular injuries, and specifically cardiac tamponade. Notoriously, steering wheels are culprits for cardiothoracic types of injuries, and cardiac tamponade is one of those things, just like a tension pneumo, and you really can think of them in a very similar fashion, that if it's not caught quickly, the outcome is going to be pulseless electrical activity and death. Over on the left, you see a normal heart, the atria, the ventricles, and the pericardial space there, the pericardial sac that surrounds the atria and the ventricles. And that typically has about maybe not even quite a medicine cup full of fluid in it, so just enough to keep things lubricated and moving as they should. In the case of cardiac tamponade, fluid has entered that pericardial space, and that fluid may have entered that space by way of an open or closed type of an injury. So with a steering wheel, it's a closed injury, and perhaps there's been something damaged and is bleeding into that pericardial space, where with an open injury, a direct insult to that space may introduce blood as well. But either way, regardless of whether or not it's internal or external, closed or open, blunt or penetrating trauma, the outcome is the same in that the pericardial sac, which shouldn't have very much fluid in it at all, has too much fluid. It puts pressure on the atria and the ventricles, and it causes them to have a difficult time contracting and expanding. So with our lub dub, if you will, or what am I trying to say? The S1, the S2, sorry, long day, atrial depolarization, repolarization, and then ventricular depolarization. What happens with this is that as the ventricles cannot pump, you're going to find that the person's cardiac output is going to be very, very profoundly affected. So what we look for when it comes to cardiac tamponade is we look for what we call Beck's triad. And Beck's triad, these are the 3 hallmark signs that something is wrong. The first thing that you're going to see is jugular venous distension, JVD. And you see that because the blood that is trying to enter the right atria by way of the superior inferior vena cava is experiencing extreme pressure. So there's too much load for that blood to get in, right? So the pressure is too great, the blood begins to back up, and that is expressed by JVD. So that's the first thing in Beck's triad. The second thing in Beck's triad is going to be a decrease in blood pressure. And it would stand to reason that if everything is compressed, if the ventricles have too much pressure on them, they're not contracting properly, so the blood is not being sent out via the aorta to the rest of the body as it should be, so the blood pressure is going to drop. And then the third and final thing in Beck's triad is muffled heart tones, where normally you should hear lub-dub, S1, S2, nice, crisp, clear heart tones. Heart tones will become completely muffled. And so when you go to listen, instead of hearing that lub-dub, you're going to hear more of a shh across the S1 and the S2. Now you want to be careful because you can have a little bit of a muffled S1, but a crisp S2 with people who have aortic stenosis. And so this is a different thing. This is, you cannot really hear an S1 or an S2. You just hear muffled heart tones when you listen. So Beck's triad is jugular venous distension, decreased blood pressure, and muffled heart tones. This is something to check for right away when your patient comes in as a trauma. Now, decreased blood pressure, they may have a decreased blood pressure from any number of other things if they have multiple injuries in their trauma, so you won't be able to go by that specifically. But they shouldn't have JVD. Think about it. There's no reason they should have JVD if they don't have a cardiac injury, because after all, if they're volume depleted, if they're hypovolemic from trauma, they wouldn't have venous distension. So that venous distension is a really good telltale. You need to learn how to measure it. We won't go too much into the details of it now, and I think you've already learned that in the past, but you do need to be able to look for that. And then very, very importantly, get your stethoscope on the chest, listen for those heart tones, and make sure you listen well enough and long enough that you can truly hear it. In trauma, there's a lot happening. It's all happening quickly, but it's extremely important that you take a good long listen to the heart tones to make sure that you hear that crisp S1 and S2. If, in fact, we have to intervene when it comes to cardiac tamponade, the thing that is needed is we have to have an ultrasound wand. So as a nurse, you're in the ED, you have a patient comes in, their cardiac tamponade, we're trying to, we're assessing and we have a positive for Beck's triad. One of the things that you've got to do is you've got to get that ultrasound machine. We need the wand to be aimed upward from near the notch, the sternum, and then pointed upward and with some pressure put on it. And so you aim upward, then the cardiologist or the intensivist, whoever the practitioner is, can see very clearly what they're looking at there is that pericardial sac, and they'll be able to view it that way. When they can view it, when they have it in view with the ultrasound, then they're going to try and use the ultrasound to guide them to insert the needle with a large syringe. And that has to be inserted on an angle very, very carefully, obviously, and with pressure aspirating back on the syringe, so that as soon as the needle enters the pericardial sac, the second it does, with that degree of pressure and aspiration on the syringe, it'll begin to fill with blood, so that we'll be able to evacuate that without damaging the structure of the heart itself. Again, just like the tension pneumo, it's kind of miraculous how quick this fixes things. As soon as that blood is evacuated, we're going to see a huge improvement in the patient. Now the problem can be, is there something still leaking? Most of the time with trauma, unless it is penetrating trauma, if it's blunt force trauma, when that cardiac tamponade takes place with that fluid entering the sac, it happens quickly, and then spontaneously, wherever the bleed was, it resolves. Now, it doesn't always, but many times it resolves spontaneously. So when you evacuate that fluid, you don't have to keep doing it. But if we have any thought at all that there's still something leaking, then of course they're going to need to go to surgery. And in some instances, when the trauma is severe enough, especially penetrating trauma, they'll have to open the chest right at the bedside. And so that happens in the ED pretty rarely in smaller hospitals, but in trauma centers, that's a regular occurrence. So with a chest wall having to be open right in the ED. All right, moving on with thoracic injuries, the aorta is a huge vessel, and one that if you look over to the left, you can kind of see where it lies back there, almost almost against the spinal cord, fortunately or unfortunately. So it's relatively protected until it isn't, and so when I think about spinal cord injuries and spine injuries, if a person has had trauma to their spine, the aorta is definitely vulnerable, and sometimes those vertebral bodies are the culprit of causing damage in that area. The aorta can become sheared, it can become stretched, it can be torn, and sometimes you'll develop a dissection, which is bleeding between the layers. Think about the layers of the vessel, and so that dissection can be a good amount of blood very quickly between those layers, and it won't be long at all before the patient's outcome is poor or it's death. And the symptoms sometimes can be difficult to get at, especially if your patient is not awake. So with an aortic injury, if it's severe enough, they're going to be blue, pretty blue from the region of the abdomen up. And usually, if that happens, it's too late to do much. You can still try, but that's usually a dissection that's pretty significant, or they're bleeding out. In other instances, they'll feel pressure, and they'll feel like they have to have a bowel movement if they're awake, and they can tell you they have this unbearable urge to have a bowel movement, but yet they don't have to go. That can be another sign of an aortic injury. And extremely low blood pressure, or they may have already coded. This aorta is high volume, and when it is damaged with penetrating trauma, it can be extremely difficult to get them to surgery in time. Importantly here, and you've probably already heard this before, but it bears repeating, if there is penetrating trauma to the thoracic region or to the abdominal region, we absolutely do not want to remove whatever the object is. So I've seen everything from ice picks, crowbars, chair rails, everything under the sun, axes that are in a patient that they've been exposed to trauma of some sort. And when they don't pull out whatever that is, whatever the object is, at least there is some chance of getting them to surgery in time before you pull it out and they bleed out completely. So the object needs to remain intact. If you're first on scene, we need to not only have it remain intact, but secure it intact. So actually, use whatever material you have to secure the item in place. If you possibly can, try to drape the patient so that they cannot see the object, because you can well imagine how distressing it would be to look down and see something sticking out of your abdomen that shouldn't be there. So try to drape or cover the patient's eyes if they can tolerate that, so that they're not looking at it. And then, of course, rapid transport. And then the object is only removed once the patient is in surgery, and they can open up the area around it and then safely remove it. With blunt trauma and penetrating trauma, there are many different organs that will be affected in the abdominal cavity. And so this just gives you, again, a kind of a quick broad overview of all the different things. And so trauma to the abdomen, where trauma to the chest is, they're at risk for bleeding out readily. Trauma to the abdomen, yes, they have that risk, but there's also the huge risk of sepsis. So when you think about the gut, you need to think about the fact that it's dirty. It's a dirty area. You've got the intestines there and food there, and so any insult to the gut, you have to worry about that third distribution of mortality, which is sepsis, days or even weeks out from the trauma. Blunt force penetrating trauma, both are going to be considerations. And this visual here, it's a little bit busy, but what I'm trying to show you here is edema in the abdomen. So we've talked already about the development of pulmonary edema in the past. We've talked about cerebral edema with trauma. Now let's talk about edema in the abdomen. When you have an injury to the gut, as soon as you have that injury to the gut, there is going to be the development of edema, right? And so you have your direct injury, whatever it was, car crash or otherwise, but then you have your indirect or secondary injury that it results from an extreme amount of pressure that can be placed on the vital organs. And so if we have a closed abdomen, the patient has not yet gone to surgery, with an excessive amount of pressure that it exceeds 15 to 20 milligrams of mercury, capillary refill is going to be reduced. And when capillary refill is reduced, then you get into a situation of anaerobic activity or catabolic activity, and the damage just really escalates. It's just a vicious cycle, right? So think about what's going to happen to your patient who comes in with blunt force trauma to the abdomen. We need to do a quick assessment to see, do we think they have internal bleeding? But even if they don't have internal bleeding, if they have contusions, if they have enough contusions and enough, if they've had enough pressure, that edema is going to build quickly, and the gut's going to get ischemic, and then you have time. Time is tissue, right? Then you have tissue damage, and that tissue damage can lead to multi-organ dysfunction and multi-organ failure. In the case of extreme pressure in the gut, you can develop compartment syndrome in the belly. And that compartment syndrome will put so much pressure on the vital organs, the nerves, the arteries, the vein, the lymphatic system, all of it, that you end up with a situation where the gut becomes necrosis, and tissue death sets in. This is kind of a gross looking picture for sure. But what I'm trying to show you here is how important it is that we don't try after post surgery. We don't try to close the abdomen anymore in trauma. So they'll do open abdomen. So they go in, repair whatever is going on surgically that they possibly can. Maybe there's a laceration to the liver, to the spleen. Sometimes the gut itself, the intestines have been perforated, and in many cases they may have to take out a certain section of the bowel. If that happens, if the bowel is perforated, you know that the content of the bowel is going to spill into the peritoneal cavity, and that has to be evacuated. The area needs to be debrided to the extent possible, and they need to irrigate. You'll irrigate with an antibiotic and saline solution to try to eliminate the possibility of E. coli being, kind of traveling all throughout that area. So a lot needs to take place, and it's not easy. And this looks pretty bad. But it's a pretty accurate depiction. This is extremely swollen organs as a result of compartment syndrome that has taken place from this trauma. So you can see where you can barely even really fit the content back in. And in some instances, they end up, again, taking out a large portion of the intestine. Sometimes they take out several feet. And it can be very, very difficult for the surgeons to find the area that is bleeding. So, you can well imagine with that much swelling, you really are having to sort through the intestines and really look carefully at every little thing to see if they can find the area that might be leaking or bleeding. And so oftentimes in the past, and I've been a nurse a long time, we would go ahead and take the patient to surgery, find the area that was compromised, whether that was the gut, whether that was the the liver, the intestine, whatever, fix it surgically, sew it up, suture it, do whatever we had to do. Sometimes do a colostomy, sometimes not, but then close the belly. Well, you close the belly, but the swelling continues. And as the swelling continues, tissue is more and more ischemic. Soon you have tissue death, and before long you have an infarcted bowel, and that bowel infarction will very easily lead to gangrene, and then the patient dies. So now, fast forward to, probably at least a good 10, 12 years now, we've been doing this really, really routinely. Instead of closing the belly after surgery, we use a wound vac. So this is a wound vac being placed over the abdomen. It looks like saran wrap. It gets placed carefully over the abdomen, and then it's attached to the vacuum drains, and it's a very slow and low pressure drain. But what that does is that lends itself to letting the belly, the swelling, go down in its own time, but with with at least a covering there, so that we're not totally keeping the not totally exposing the abdomen to everything. In past, before the wound vac, we would, if we're going to do an open abdomen, we would literally just drape it with sterile towels, and that was typically a pretty bad outcome too. The patient's got massively septic. I'm not suggesting that they don't get septic with this, they still do, but it's a much, much better outcome than in the past. So the science has really evolved. Your role as a nurse is to assist when they're putting on a wound vac. They're going to put the wound vac on, usually in surgery. But when they come back, you make sure that's functioning appropriately, monitor the drainage very, very carefully for changes in volume or changes in the way that it looks, if it begins to look purulent, if it looks like it has stool in it, all of that kind of stuff. And then usually every other day, somebody who has an open abdomen is going to have the procedure where they pull off the dressing, they do an irrigation, they inspect the gut, make sure they don't see any evidence of any further bleeding or any further leaking of the intestine, and then replace the covering and hook the wound vac back up. So that's usually, and every other day they'll call that a washout, and it's a sterile procedure. The sterile procedure is done right at the bedside, unless they have the luxury of being able to take the patient to the OR, but usually it can be done in the ICU right at the bedside. And here's a wound vac. So once it's all connected up together, that little area that you see that's black there, that's really just like a foam, and that can fit right into a wound. Then from there, the vacuum is attached to the device there, and then we turn that on using, again, a low, slow pressure. So when you get a patient who comes into the ED and we have an abdominal injury, whether blunt force or penetrating trauma, we need very quickly to try to find out what exactly is going on. So the fastest way to do that is to use bedside ultrasound, and we use the acronym FAST for Focused Assessment Sonography Trauma. So you're going to call the ultrasound tech to the bedside emergently. In a level 1 trauma center, they're always available 24/7. They're going to come and do a focused assessment of the abdomen to see if they have any evidence of injury, whether, again, to the spleen, the liver, the kidneys, etc. If you don't have the ability to do an ultrasound immediately, another thing you can do is a DPL, which is diagnostic peritoneal lavage. And that DPL, we don't see this very often now because we have the ability to do the ultrasound so quickly. But you can do a diagnostic lavage where you're basically just tapping into the peritoneum with an angiocath, hooking that up to sterile tubing in a bag, and then by drainage just let it drain. So what happens is you would first put in the tube, the angiocath with the tubing attached to it, and you would go ahead and you would inject, not inject, but by gravity you would let a liter of fluid go in, right? So using just regular IV tubing, right? So it's hooked to, say, saline in the bag, IV tubing into the peritoneum, and then as soon as that liter has drained into the peritoneal cavity, that same bag, don't take it apart or anything, just take that same bag down off of the IV pole and lower than the belly, and by gravity the fluid is now going to come out. And as the fluid comes out, it should be clear. It should be clear. But if they have abdominal trauma, it's going to be bloody, or it may even have bowel content. Lord knows what it might have in there, right? So this is a way for us to see, is there a positive return in a DPL? So again, IV fluid injected into the peritoneal cavity, and then once the fluid is injected, just by gravity, we lower it down below the abdomen, let it drain, look for the presence or absence of blood or other bowel content, things like that. And the other thing you can do with it, and we typically would do if we had the ability, is take that fluid then and send it to the lab to have it analyzed to see, what else does it have in it. Thinking about amylase and lipase and glucose and all the kinds of things that could be there, and those can help give you some information. It's not a thing of the past, but it's not done as often, except maybe think about more like a field unit or an area that doesn't have as much technology. But it is a very, very useful tool to know, do we need to open up the belly? In abdominal trauma, the liver is probably one of the more dangerous things in the first phase of the trimodal distribution of mortality, and that is because lacerations of the liver cause massive, massive bleeding. So here you see the grades from 1 to 5 of liver damage, and grade 1 is a laceration. So a laceration less than 10% surface area, usually less than a centimeter deep. These are, it's not that they're not going to bleed a good bit, they will, but they're not as threatening, of course, as the grade 5, which in a grade 5, we're talking about like basically total lobe disruption, right? And in this case, maybe the liver is totally evolved and there may be a portion of it that is completely, totally disrupted or detached from the rest of the liver. In a grade 5, a patient may bleed out before they ever get to the emergency department. So this is something that needs to be caught quickly or it will advance to death. So the definitive treatment for this is operation. It's the only thing that we can do. A patient that comes in with abdominal trauma that's showing us massive signs of septic shock would go straight from the ED to CAT scan to OR with nothing in between, and we would be talking about people racing to get from one place to the other. So a whole team of people getting the person to CAT scan so that we can see if the focused abdominal ultrasound didn't show us anything, they'd go to CAT scan. If the focused assessment shows us what we need to see, then we would open the gut immediately. Sometimes at the bedside, preferably in the OR, because the chances of sepsis with abdominal injuries are so great. Here you see spleen injuries, and spleen injuries are also graded from 1 to 5. And so the spleen injuries being graded from the level of just a little small laceration all the way on through to something very, very severe where the spleen is totally shattered. The spleen is very, very vulnerable as far as the abdomen goes. It's one of those things that in abdominal trauma, we can almost count on, it seems like, the spleen having some sort of damage to it. It just seems like it's kind of delicate. That's just anecdotal, but I've seen that so many times over the years. With spleen injuries, what we'll do, if possible, is try to save the spleen. In years past, we used to always just take the spleen out. You can live without it. You can live without the spleen. You can live without your appendix. And so they would just take it out. But they've certainly, through the years, evolved more and decided that based on the research that the spleen really does play a pretty decent role in fighting infection. So if it's possible to salvage it, that'll be the case. And so maybe sutures, and sometimes they'll have to put in some drainage material. They may have to have a drain inserted if they're going to have a closed abdomen, or if they're going to have an open abdomen, then again we'll use a wound vac. But the important thing with spleen injuries is that if we end up having to do a splenectomy, which in major trauma is a real possibility, that patient must have a pneumococcal vaccine before they leave the hospital. If they don't have a pneumococcal vaccine before they leave the hospital, they are very, very vulnerable to pneumococcal infections, pneumococcal pneumonia, and there have been several instances in the last couple of decades where patients have sued because they've developed pneumonia, and in a few cases the pneumonia was fatal. It was pneumococcal pneumonia that was very, very serious and fatal. And if the patient didn't have the pneumococcal vaccine post-splenectomy, we would be liable for that. So it's extremely important that we don't forget this. It's a small thing to think about, but yet it can become a life-saving measure to make sure that vaccine is given prior to discharge. All right, so a little bit about genital urinary injuries. We won't spend too much time on this, but probably the most important thing to consider here is the kidneys. We all know that the kidneys, serve a major function to help us with our fluid and electrolyte balance. They help us to filter and eliminate waste. So they're extremely important, and you can't live without them unless you're going to be on dialysis. When the kidneys are injured in trauma, one of the first signs that you're going to get is that you'll see that a person will experience a retroperitoneal hematoma. So on the flank, so in the back. So when you do your survey, when you're doing your primary and secondary survey, and you log roll your patient to take a look and see, to their back, they may have bruising, ecchymosis and bruising around the region of the kidneys on the left and the right flank. So this is something important to note. They may have other signs as well, but that would be one, and many times it's extremely painful if they're alert and oriented. If there is damage to the kidney, the ureters, the bladder, or the prostate, any of these areas, many times we have to do a urinary diversion catheter. So sometimes I can't do just a Foley, may have to do a suprapubic catheter. And if there is damage to the kidneys themselves, then the definitive treatment for that would be to surgically repair those. When it comes to damage to the genitourinary system and post-operative care, one of the things that's probably going to take place is you may see that they have a three-way or continuous bladder irrigation to make sure that clots don't accumulate, and that bladder irrigation needs to probably stay in place for a couple of days. And so your nursing intervention would just be to be very careful, again, with I&O. Intake and output can be tricky when you're irrigating solution in, so you need to make sure you subtract that irrigant, of course. And then to make sure that we keep that irrigation flowing smoothly, that if clots develop, that we work quickly to evacuate those clots. And sometimes it's a simple matter of speeding up the drainage a little bit, but you do have to be careful. The fluids need to be warm, and they need to be not moving too fast, because you can really get a person in a lot of pain with spasms if we try to inject too much fluid all at once. So in addition to the fact that this is a bleeding event, just by virtue of the fracture, you may also see an impaired production of red blood cells, moving forward with this fracture. Now, the mechanism of injury can be important, whether it's blunt force or penetrating trauma. Of course, we're going to consider that, and we're going to consider the location and whether this is a stable or an unstable fracture. When we're evaluating the pelvic region, you'll do what we call rock the pelvis. And so the patient is laying flat in the bed. You take both of your hands and you press down on the left and the right side of the ilium. And as you're pressing down, you're trying to feel, is there any crepitus there? Is there any kind of a crunchy feeling there? Is there some irregularity? Does one side feel different than the other? And you've got to be careful with this. I mean, if it's an unstable fracture, you can really do damage. And so, you need to be trained to do it. But we're going to rock the pelvis briefly to try to see if there's anything that's obvious. Typically, when there is a pelvic fracture of any major substance, it's going to be pretty obvious, the irregularity. There's deformity there. The femur may have also been dislodged, and so you may see the foot pointing outward. You may very obviously see dislocation at the hip, and it is excruciatingly painful. So with pelvic injuries and fractures, there are several different ways that the pelvis can be fractured. And this is showing you that in illustration number 1, the blade of the ilium is fractured, the floor of the acetabulum in 2, and so on. In some instances, we have what's called an open book pelvic fracture. And I'm not sure that I have a picture of that, but if you look to number 5, where it talks about a hinge injury, and think about whether that area down there that's marked in red kind of coming apart, if you will, so that the left and the right are separated from one another. And that is called an open book pelvic fracture. It's very, very damaging to the internal structures, the underlying structures. And think about it as a crucial location, because there at that ischiopubic ramus, you've got nerve, artery, vein, and lymphatic systems running underneath that, including your femoral artery, which is huge, right? So if you have a fracture there and it's an unstable fracture, it's not at all out of the realm of possibility that unstable fracture can do damage to those underlying structures, including the possibility of rupturing that femoral artery. And in that case, the patient may or may not even live long enough to get to the hospital. When we see open fractures or open book pelvic fractures, I got to say that oftentimes the injury, the mechanism of injury, is a motorcycle crash. So motorcycle crash, think about it as, of course your legs are straddling the motorcycle, and if you crash and your body is still on the motorcycle, the open book pelvic fracture is going to occur from the pressure that the seat itself puts on the patient. So motorcycle is extremely dangerous. Pelvic fractures are really, really common when it comes to motorcycle crashes. When you have a patient who's got a pelvic fracture, looking for obvious deformity, excruciating pain, sometimes dislocation. When we go to log roll the patient, if you are doing your primary and secondary survey, you may see that they have bruising or ecchymosis at the anus, which sounds like a strange thing, but sometimes they'll have a kind of a ring around there that is ecchymotic or very, very bruised. And again, they're absolutely, if they're conscious, they're in terrible pain. They tend to be hypovolemic very, very quickly from the blood loss. They can go into hypovolemic shock. So this is a definitive surgery as well. They're going to need to go to surgery, but sometimes they're not even stable enough to get to surgery because of the massive blood loss. So at times we have to fluid resuscitate first and get them even stable enough to move. Here you see, excuse me, here you see medical and surgical, medical management of a pelvic fracture that is acute. I can't really tell where the patient is, but it looks like they're on the floor, and they must have had an obvious, an obvious sign of pelvic fracture. If we rock the hips and we feel that there's crepitus there, there's movement there, there's irregular not equal movement on both sides, something like that, and we suspect a pelvic fracture, it's important to immobilize. So in this instance, they're just using a sheet, and they're just putting the sheet tightly around the pelvic region to just try to make sure that they stabilize the pelvis enough that nothing moves. Because again, keeping in mind underlying structures and the damage that can be caused to the nerve, artery, the vein, or the lymphatic system, should those bones move around and penetrate something, it could really be a terrible outcome. All right, now let's shift gears and talk a little bit about the complications of trauma. So one of the first things I want to mention is the risk for fatty emboli. All right, and we see this when there are fractures. So multiple fractures especially, the patient has a huge risk for an embolism breaking loose and traveling and causing pulmonary embolus, causing a stroke, those kinds of things, really, really bad outcomes. So when we have multiple trauma, if we have somebody who has major damage, lots and lots of fractures, one of the things that we think about doing is inserting an inferior vena cava or IVC filter. You may know this as Greenfield filter as a brand name, but the IVC filter is a really cool little device that gets inserted into the inferior vena cava so that as blood is traveling back from the body to the heart, and before it reaches the heart, if there is any clot in there, now these are very, very tiny, if there's any clots in there, they'll be caught in this little filter and they will not travel to the heart. And then as a result of not traveling to the heart, they won't be catapulted out to the rest of the body as they enter the heart and then ultimately circulate through, potentially to the lungs, again, causing a pulmonary embolus. Or if they get all the way to the left ventricle and they head out, they may indeed cause a stroke. So an IVC filter can actually be put in at the bedside. Not many hospitals do it, but the level 1 trauma centers definitely put them in at the bedside using radiology specialists. If not, if the patient is stable enough that they can be taken to radiology, then they can be inserted there. And these little filters are truly life-saving, but they have to be done proactively. We have to be thinking about this ahead of time. So multiple fractures, definitely a patient who may be a good candidate for an IVC filter. Other complications include hypermetabolic state. Your patient's caloric needs are tremendous. And one of the big mistakes that we make in trauma is not feeding our patients soon enough. So if you don't feed your patient soon enough, not only do you run the risk of them not healing well, but also you run the risk of them developing stress ulcers. If we can drip tube feeding into the gut, that's so much better for keeping the normal flora intact, for not developing supra-infections, and for just keeping the gut working. So if it's at all possible, we need to consult nutrition, have them come take a look, see what the caloric needs are going to be, get a feeding tube in place, obviously be very, very careful about the risk for aspiration, but make sure that the patient is fed. If it is not possible to do enteral feedings because there's major abdominal trauma, then it would be time to get TPN sooner rather than later. Yes, it's expensive. Yes, there are risks, but the risks of not feeding your patient are far greater than anything that I could think of related to TPN or tube feeding. We've talked about infection some, particularly high incidence of infection with injuries to the gut, gunshot wounds to the abdomen, those stabbings, things like that. Their outcomes at the outset may be okay, but then that you get out 2-3 weeks and you've got massive sepsis, and sometimes that results in multi-organ failure. Pulmonary complications can certainly happen. We've talked a little bit about that. Your patients who are trauma patients are definitely at risk for ARDS. Trauma is an independent risk factor for ARDS. But in addition to that, you think about the possibility of aspiration and other things. And so really got to watch for those signs and symptoms of respiratory distress and the development of ARDS and be proactive about that. And then managing pain. So oftentimes we sedate our patients who are trauma patients, but then we don't really think about the underlying pain. Now, sedation does not equal pain medication. So you need to really be an advocate for your patient to have pain medication on board at all times. You know, they're obviously in excruciating pain if they were awake and could talk with us. And if a person is in pain, even though they're sedated, they're definitely not going to heal as well. Their system is going to be stressed. Their blood pressure is going to be higher. They're going to be breathing faster. It's really just putting such a stress and strain on the body from a hormonal, chemical, and neural standpoint. So we need to be advocating for pain medication. I know that sometimes blood pressure can be a challenge. We're better off to use vasopressors, get the blood pressure higher, and then still give the pain medication, as opposed to saying, oh, their blood pressure's too low, let's just skip the pain meds. Other complications of trauma, multi-organ failure is a huge one. Acute kidney injury, and we've talked about kidney injury already. This would be an incidence where we would have a pre-renal type of a situation from hypotension, right? So pre-renal is a huge risk. Now, if there's damage to the kidneys directly, you may have intrarenal and you may have post-renal. So it's possible that you could have all three. Another thing that's really dangerous is the development of rhabdomyolysis and or myoglobinuria. And rhabdo comes from muscles being damaged. And we've talked a little bit about this in the past, but when muscles are damaged, they release an enzyme. And when they release that enzyme, as it begins to travel, it should be broken down and it should be excreted in the urine. But the molecule is rather large, right? Think about it that way. It's kind of a large cell, all right? And so because of that, it's difficult to filter. And when it's difficult to filter, gets into the kidneys, sometimes causes intrarenal types of issues. And sooner or later, the urine output begins to drop off and the urine becomes darker and darker. Now, I'm going a little bit fast here. We could do a whole lecture on myoglobinuria and rhabdo. But muscles, when you have massive muscle damage, be thinking proactively about the possibility of a person developing rhabdo. So if you have somebody who's come in with a crushing injury, they're a prime candidate for this. And I took care of somebody who had both legs crushed between two vehicles one time, and he managed miraculously to survive the initial trauma, only to develop rhabdo later on and ultimately not make it. And I think that we, had we been more proactive, and this is a long time ago, back in the 80s, but had we been more proactive, perhaps the outcome would have been different. So when massive muscle damage happens, we need to flood the patient with fluids. They need a lot of IV fluids. We need to keep those kidneys flooded and hydrated as possibly can be, and be watching for that urine to become darker and darker. When a person is having myoglobinuria, it's going to look like iced tea. It's a tea-colored urine. So you can see that urine getting darker and darker. You should be suspicious for that. You should report those symptoms right away, and more than likely going to do a lot of IV fluids. In some instances, we end up having to do dialysis, but the biggest thing here is to be proactive and be thinking about it, because muscle damage very often can lead to this. All right, another potential complication of trauma is compartment syndrome. We've talked about compartment syndrome to the gut, where we would end up opening the abdomen and keeping the abdomen open, using a wound vac to protect that area and to evacuate any drainage. But compartment syndrome can definitely happen, and happens all too often in the arms and the legs. Now, there's really not a lot of room in the arm. If you think about the arm and you look at your arm, if you've had some trauma there, especially closed trauma there, as the swelling begins to develop, there's no place for it to go. And so very soon, it's going to be like the arm is totally constricted. And if you look at the image there down below, the swelling of the muscle causes such significant compression on the nerves and the vessels that before long, they may not have a pulse. So with trauma patients, you need to be monitoring peripheral pulses very, very carefully and document them. And as you document them, if there's any change, if they go from a 3 to a 2, a 2 to a 1, or a 1 to a Doppler, you need to be reporting that and letting somebody know. If you had a pulse in the extremity and now you suddenly do not, that is a surgical emergency. It's absolutely life and limb. So when you report that, you need to be prepared in trauma for the possibility that if compartment syndrome exists, they're going to need to do a fasciotomy. And that fasciotomy is done, again, typically right at the bedside. We don't usually wait. We usually drape and cut right away to relieve the pressure and hopefully be able to save that limb. It's going to restore blood flow to the periphery. So this just shows you an example of fasciotomy. And here they're showing you, this is copyrighted, sorry about the image copyright, but here they're showing you that the fingertips have become cool and purple. Obviously they have lost their pulse, and what will be done is the fasciotomy is performed just to relieve that pressure, to allow that swelling to have some place to go so that we can restore blood flow and save those extremities. With those purple fingers like that, it would take no time at all for them to end up at least losing the tips of fingers, if not sometimes the whole hand. So this needs to be proactive. Again, it's going to happen quickly. So if you notice that the patient has developed some blue periphery, they've got cyanosis, they're experiencing numbness, tingling, the extremity looks cold, or feels cold and is pale. You need to be looking at that very, very carefully and getting in touch with the doc and preparing for the possibility of that surgical procedure. All right, a few other final complications. Multi-organ dysfunction, which is going to be another lecture. We'll talk about it in some detail. And then missed injury, and I'll tell you a quick story about this as we wrap up. And that is that I took care of a patient many years ago who he had a head injury, but he didn't have a major bleed, and he was relatively neuro intact. We intubated and sedated him so that we could, just protect his airway and kind of just keep him calm for a couple of days so that he could recover. He had a few other injuries. They weren't terrible. I was working night shift, taking care of the patient, went in to do my neuro assessment, and found his pupils to be unequal. And I had no understanding whatsoever of why those pupils would be unequal, because he was neuro intact the prior shift. So I got the other nurse and I said, come look at this. Oh yes, the pupils are definitely unequal. What's going on? Call the neuro doc, call the ICU doc and say, hey, we've got a change in neuro status. And the doctor hung up on me, said he has no head injury. He has no bleed. His pupils are not unequal. Basically just said, like, you're crazy. His pupils are not unequal, and he hung up. Well, it got worse. And before long, he started developing decorticate posturing. And that decorticate posturing was very, very obvious. And so, his neuroassessment was going downhill, coma scale very, very low, posturing, reflexes changed, all that stuff. And I called back and I said, look, you got to get in here. You need to get in here. So they said, okay, take him to CAT scan. Took him to CAT scan, no bleed in the head. So they basically blew me off again and said, well, I don't know what you're talking about, but he has no bleed. Nothing is worse. Stop calling me. Well, by morning, the patient had progressed even further, and ultimately he died. And what they found in the autopsy, was that he had a seatbelt injury, and the seatbelt was too high, and the seatbelt was in such a place that it caused a carotid dissection. So his carotid artery was dissecting. The entire time that I was watching him go downhill, his carotid artery was bleeding between the layers, and he died. So this was from a seatbelt that was too high up on the neck, riding up too high. And I know you've all experienced that when you get into a car. You need to make sure that seatbelt is down where it should be, because a seatbelt across the neck is something that could be catastrophic. This was a missed injury, and the patient should have lived, but he didn't. We didn't catch it. So important that we do a full survey. If you see something that doesn't fit, you got to keep asking. You got to keep looking. Sometimes you might ruffle some feathers, but you really have to get somebody else to come and take a look at your patient. Call the doctor. Be persistent, because typically if you think something is wrong and something is just not sitting well with you, you should really trust your instincts. All right, and then some other things here with consideration. The family really becomes your patient, especially if it's a catastrophic trauma and the patient isn't likely to survive. At that point in time, you really have to think about how the family is going to process this. And sometimes when a person progresses from trauma, from a traumatic brain injury, they progress quickly to brain death. The family just has no ability to process it, especially if it's a very young person. So we may have somebody who's in the ICU and has been pronounced dead from a brain death perspective, and we may keep them on the ventilator for a day or two and allow for family to arrive. And that may seem counter to anything that you could think of would be okay. But again, thinking about who is your patient now. If your patient has progressed to brain death, now the family is the consideration. So do involve all of the disciplines, pastoral care, anybody that you can, get as much support for the family as you can. And then trauma in the very young and the very old, we didn't talk about it very much, but suffice it to say that there are no compensatory mechanisms, when a person is quite elderly. So with survival, the patients who tend to do the best are, the young folks, not very young, but from teenage years up into about 30, 35, something like that, and then it kind of goes downhill a little bit more. But that younger population, those 20-somethings who, fortunately or not fortunately, tend to be the ones who have the car crashes, they tend to do pretty well. But you get somebody 50, 60, 70 years old, has a massive trauma, and they struggle a lot more. And that's just, obviously that goes without saying. All right, that's it. Long lecture. I hope you've enjoyed it. I know that it was a lot of material, and there's still much more that we could talk about. I'm sure you probably have questions. This is not meant to be all-inclusive. You need to do your reading. Really study this chapter carefully. It is something that, not everybody's going to be a trauma nurse, but at some point in your career, you're likely to be exposed to someone who has experienced trauma. And knowing what to do in that golden hour, those first few minutes up to that first hour, to save tissue and to potentially save the person's life is absolutely key and crucial. So I hope you've enjoyed it, and have a good afternoon.